Hello, everyone. Welcome to today's session. We will be starting in about a couple minutes, so we will let you know when we start. Thank you. Hello, everyone, and welcome to today's session. On behalf of the Special and Vulnerable Populations Task Force, we'd like to welcome everyone to our first webinar of the four-part National Learning Series focused on comorbidities associated with diabetes. Our first webinar today will discuss using referrals, outreach, and care coordination to address oral health and diabetes. My name is Joe Lee, and I am the Training and Technical Assistance Director of the Association of Asian Pacific Community Health Organizations, or also known as APCHO. I am joined by my colleagues, Albert Eisen and Christine Alarcon, as well as Jillian Hopewell from the Migrant Clinicians Network, and we will be serving as your moderators for today's webinar. This National Learning Series was created to address our diabetes epidemic, which is affecting more than 30 million people across the U.S. To combat and continue the national conversation around diabetes, the Special and Vulnerable Populations Task Force created this series to increase knowledge of effective strategies to prevent, treat, and manage diabetes among health center program patients. 13 National Cooperative Agreements, or NCA organizations, funded by HRSA, have partnered to create meaningful content and provide access to expert guest speakers for our audience today. We'd like to acknowledge HRSA's support in our task force efforts and decreasing the percentage of health center program patients with A1C greater than 9, and we are excited to develop a clinical change package for diabetes care, which will be published later this year. Our National Learning Series will be utilizing the Diabetes Continuum of Care framework, and today's webinar will be focused on optimizing provider and multidisciplinary teams as one main strategy for diabetes prevention and management. And today's agenda will include a 90-minute presentation with a Q&A immediately following. Our learning objectives will be threefold. One, to describe why accessing oral health care for patients with diabetes is both essential and difficult. Two, to identify the roles and responsibilities integral to a patient-centered, multidisciplinary care team. And three, to describe the function of outreach workers in care coordination and on a care team. I'm really excited to introduce you to our speakers today. First off, we have Dr. Irene Hilton, who works as a dental consultant for the National Network for Oral Health Access, or NOHA for short. NOHA is a nationwide membership association that exists to promote access to oral health care for underserved populations by encouraging community health centers to start and maintain dental programs and to provide training, technical assistance, and networking for professionals who work in the safety net. Next, we have Emily Kane, who works as the Senior Program Manager at the National Nurse-Led Care Consortium, or NNCC for short. NNCC is a member organization dedicated to advancing the principles of nurse-led care through policy advocacy, innovative public health programming, and training and technical assistance. And lastly, we will have Diana Lieu, who works as the Senior Manager of Health Outreach Partners, or HOP for short. HOP is a national nonprofit organization that works to build strong, effective, and sustainable grassroots health models by partnering with local community-based organizations across the country in order to improve the quality of life of low-income, vulnerable, and underserved populations. So before I hand it over to our speakers, I want to review a few housekeeping items and let you know how you can participate in today's webinar and engage with our speakers. Here, we are looking at a screenshot of the GoToWebinar attendee interface, which is made up of two parts, the viewer window on your left and the control panel on your right. The viewer window allows you to see everything the presenter will share on their screen, and the control panel allows you to participate in the webinar. Please note that all attendees are in listen-only mode and will be muted during the webinar. You may submit questions during the presentation by typing them in the questions field of your control panel, and we will be reviewing these questions as they come in, and we'll address them during the Q&A session held after the presentation. Today's webinar is being recorded, so please sit back and relax. All attendees will receive an email with a link to view a recording of today's presentation after the webinar. And lastly, feel free to interact with us on Twitter at @AppShowTweets and use hashtag Diabetes National Learning Series. We'd also like to let folks know that we are offering CME and CNE credits. This will be made available, so please complete the post-webinar survey if you'd like to receive CME or CNE units or a certificate of attendance. You will have the option of indicating whether you'd prefer an electronic or hard copy of your certificate. And for any questions, please contact our colleague Martha at malvarado@migrantclinicians.org. Okay, so without further ado, I'd like to introduce you to our first speaker for today's webinar, Dr. Irene Hilton, who is a dental consultant at the National Network for Oral Health Access. Dr. Hilton, you may go ahead. Hello, Dr. Hilton. Are you on the line?
Okay, sorry about that. I was and couldn't unmute.
Oh.
Anyway.
Oh no.
Thank you, Joe.
There we go. Now we can hear you. Thank you.
Sorry about that. Thank you very much, Joe, and all the other coordinators and moderators of the webinar. This is Irene Hilton from NOAA. I'm going to be starting off by talking about accessing oral health care for patients with diabetes. Remember that you can have good health if you have bad teeth. Okay, let's see if the technology works, and I can forward. Let's see. Okay, here it is. No, here it isn't. Okay. Sorry about that. You know how the technology is. So as Joe mentioned previously, this webinar is part of a series, and this particular webinar is going to concentrate on the middle column about optimizing provider and multidisciplinary teams, and specifically the areas that are highlighted about team-based care, case management, and I'm going to be talking about the dental piece of the screenings of the eye, foot, dental, and kidney screenings. And we're going to tie it all together for you and show you how these three things can all work together to improve access to healthcare and improve the overall health status of patients with diabetes. So to kind of lay the foundation for the rest of the webinar, I'm just going to spend a little bit of time talking about the relationship, or reminding everybody about the relationship between oral health and diabetes. What we know from research and the evidence base is that there's a relationship, again, between oral health and the status of your mouth, your teeth and gums, and having diabetes. And some of the kind of side effects or results of having diabetes is gum disease, or periodontal disease, which is gum disease. You can have dry mouth either from diabetes itself or from many of the medications as a side effect of the medications you're on to treat diabetes. Dental cavities, again, because if you have dry mouth, your saliva is actually a buffer for the acids that cause dental cavities and that melt your teeth, and if you have less saliva, you're at risk for more cavities. Again, tooth loss, either because of cavities or because of the gum disease. Oral candidiasis or thrush, again, found more prevalence in patients experiencing diabetes, burning mouth syndrome, and also alterations in taste. Okay. So here's an example. These are just a couple of clinical photos. Patients with diabetes, there's a certain kind of periodontal disease, especially if they're out of control diabetics, where you get kind of like this exudate that comes from the gingiva, and you can see in the picture on the left that the patient's teeth are starting to move. Again, this is because of the bone loss. That again is more prevalent in patients with diabetes compared to patients that don't have diabetes. So here's another example, and again, this just sort of show kind of like the way that sometimes we don't think about oral health care, maybe in the same ways we do systemic health. You know, here's an example of a foot ulcer on a patient with diabetes. And when you think about all of the care and all the systems and follow-up care and attention that's kind of paid to something that is, again, a chronic infection in this kind of area, you know, again, approximately, I think it's 3 centimeters, you know, and when you look at, you know, inside the person's mouth, and if they have, again, another chronic infection, this time gum disease, and if you add up the area, you know, of people's gums where they touch the teeth, it's, you know, 3 times the size, 4 times the size of this ulcer, and yet, you know, up to now there hasn't been as much attention, you know, paid or systems created to get, you know, somebody that has that kind of oral health condition that impacts their diabetes into care. So what we know is that, and again, the research shows is that persons that have diabetes have higher prevalence of periodontal disease, and those that have periodontal disease have more severe disease than patients that don't have diabetes. And it also works the other way. We understand that having chronic periodontal disease can adversely affect the ability to do glycemic control in patients with diabetes. However, when you look at clinical trials, and most of the clinical trials have been done on patients whose baseline A1C was between 7 and 9, and those have shown that if you treat periodontal disease by doing the deep cleanings, it only has a short-term effect of lowering the A1Cs. It really only lasts about 3 months. And again, so the science is unequivocal as far as like what is the proper kind of like treatment in order to, you know, have a real effect on the A1C level. But nevertheless, you know, having a chronic infection in your mouth is not good for anyone. So we think about like whether the systems to get patients that have diabetes into dental care. So part of this, the first phase of this, is HRSA's Integration of Oral Health and Primary Care Practice Initiative. It came out in February of 2014, and this is the white paper with the link. And then on the right-hand side is a resource that we developed at NOAA through our cooperative agreements with HRSA to do training and technical assistance on how to implement for primary care providers, you know, in health center, primary care clinics to be able to perform the 5 oral health core clinical competencies that are listed in the white paper on their patients. And diabetic patient is a good example of a patient population that could benefit. So here are the 5 oral health core clinical competency domains. You can see that it's a risk assessment for oral disease. So for example, in a diabetic patient, it would be, you know, what's their risk for either cavities or gum disease. oral health evaluation or looking in the mouth for, gross pathology, preventive interventions, and communication and education about, fluoridated, toothpaste and tap water, and brushing your teeth and going to the dentist, and then interprofessional collaborative practice for being able to get patients, to refer patients and get them the dental care that they need. So here's a clinical case. This is Mrs. Garcia, and she's 70 years old, and she was recently diagnosed with diabetes. And as part of her care in the health center, she's talking to a diabetic outreach worker that's helping her go through some self-management to improve her diet and make healthy food choices, as part of her overall diabetes control strategy. Then Mrs. Garcia says that she really can't eat the fruits and vegetables that that is being suggested to her because her teeth hurt when she bites like a piece of celery. There could be many reasons. It could be because she has cavities, or it could be because she's had, advancing gum disease and her teeth are loose. So here we have an example where a person's oral health condition really impacts, their ability to make the choices that will help them, again, improve their diabetes. So as primary care providers or health workers that are working with people that have diabetes, the question is, to ask is, are you having any problems with your teeth, pain, bleeding gums, problems eating, eating all types of foods? When was the last time that you went to the dentist? And, do you have, a usual source of dental care? Are the questions that can begin to answer or lead the way to a solution. So when you're looking in the mouth, and again, you're just looking for, just the most obvious pathology. Again, the signs of gum disease, which again is an infection, the bleeding, red, swollen gums, bad breath or taste, the teeth are loose and moving. For dental cavities, holes, obvious holes in the teeth, or patients that tell you that they have pain when they're eating hot or cold foods. So in terms of the referral, interprofessional collaboration, so, you're talking to Mrs. Garcia, and she tells you that it's been 5 years since she had her last dental visit, which was for an extraction. And or you find out from her that the reason this is because you live in a state, you and Mrs. Garcia live in a state where your Medicaid adult benefit only covers emergency services or emergency extractions. So what do we do in this case where access is limited? And those are the challenges. I mean, there are definite challenges in accessing dental care if a person needs surgical intervention, which either is extractions or fillings or treatment for periodontal disease. And one of the first challenges is funding, because Medicare doesn't cover dental treatment, and state Medicaid programs may not cover adult dental care, or they may not cover periodontal treatment if they do provide some dental coverage. Here's a table of state dental Medicaid dental benefits, and you can check on the link for your own state. And you can see that we have some states that don't offer any benefits for adults. We have some, quite a number, over a dozen that are emergency only, like the state that Mrs. Garcia is from. And then the remaining states, are limited, which again may or may not cover, let's say, for example, periodontal or gum treatment. And then 17 states, or less than a third, do extensive or comprehensive care. So again, that's a barrier for patients with diabetes, depending on what state they live in. So we also have, even in the health center settings, we have challenges. We have capacity challenges, because even though it's true that 78% of health centers have at least one site that has dental in it, or they contract with a dentist, if you look at the UDS, the total capacity of health centers, the dental programs, I think it's about 6 million users, unduplicated users in 2017 is 26% of the primary care capacity. So again, we have our own challenges as well as the funding issues. So when you think about ways to increase access to dental care, we have the traditional, brick and mortar expansion, just open up another dental clinic if you're a health center. There's mobile programs. Now we have the emergence of teledentistry or virtual dental home for remote treatment, contracting again with community providers, academic partnerships with dental education programs to increase workforce, and again, the integration of oral health and primary care practice. However, there's other ways that we can facilitate getting our patients with diabetes into dental care in other services, and that would be the role of team-based care and care coordination as a way, again, to assist our patients in navigating these very complex dental safety nets. And that's what we're going to be talking about right now. So this is my segue. These are just some resources. When you get the slide deck, if you want more information, this is my contact information. And now I'm going to turn it over to our next presenter, Emily Kane, who's going to talk about the role of team-based care in accessing oral health care. And I think we're going to try to do the technology again as we switch presenters.
Great. Thank you so much, Dr. Hilton. And let's see if the technology continues to work for us. So far, so good. So yeah, so thank you, everyone. And thanks for joining us today for this presentation. As Dr. Hilton mentioned, this is the first in a series of webinars that we'll be doing as a national learning series around some of these interventions that we can implement in our practice to sort of help care for individuals with diabetes and comorbidities. So I kind of wanted to start and thank Dr. Hilton for that really great overview of some of the concerns that we see and overlap that we see with patients who experience both oral health and diabetes as comorbidities. I want to think about the ways in which team-based care can enter into our framework and how we address some of those things. Team-based care is how we operationalize teamwork. So in a team-based care setting, patients and families are positioned at the center of the healthcare experience, with clinical and other healthcare team members aligned with the patient's needs and goals. So, before I get too in the weeds with that, I actually want to go ahead and just get a poll, get a sense from you guys about what your practice, currently operates with. So, does your health center operate with a team-based care model? And it could be, the answer to this question is probably going to be different for everybody, but would you consider, as a health center staff member, would you consider yourself as part of a team-based care model? We'll just give everybody a couple seconds to answer that poll. And Joe and Albert, I'd love to see the results once we get a good number of responses there, just to get a sense from folks.
Sure. We are in the process of, sorry, we experienced a slight glitch, Emily. So
no problem.
We actually closed the poll too soon, to tell you the truth.
Okay, no problem.
We're actually going to try relaunch the polls, and we're going to do that right now. Okay, so the poll is
great.
So if folks can participate in the poll, that'd be wonderful. Sorry about that glitch.
Oh, no problem. And again, I know this team-based care is definitely a wide definition, so feel free to just give your best guess there.
Okay, we'll be closing the polls now and showing the results.
Great. Oh, wow. I'm so glad to see that. So we have some folks who aren't sure and some folks who say, no, we don't, our health center doesn't operate with a team-based care model, but it really looks like the overwhelming majority of you do. And that's such great news to hear. So that then a lot of this will hopefully be a refresher for some folks, and then maybe we'll highlight some concepts that you can incorporate into existing team-based care models that you have at your health center. And if you currently don't have or don't operate within team-based care model, maybe this can give you some interesting food for thought about maybe moving on to think about starting to implement a team at your health center there. Great. Let me just get the slide advancing. For some reason, it's not wanting to advance for me, which is kind of strange. Joe, would you just mind advancing to the next slide, and then I'll see if I can grab it back after that.
Yeah, we are experiencing a weird glitch on our end.
Oh, okay.
So the slides.
No problem.
Okay, there we go.
That looks good. Thank you. So I chose to show you this definition of team-based care from the National Academy of Medicine. In particular, I want to highlight the words collaboratively, shared, and coordinated as part of this definition, because they help illustrate what I think is a key component of team-based care, that there is no top-down hierarchy. Rather, all participants in the healthcare team play a role in improving health outcomes by deliberately coordinating with all members of the care team, including patients and families. So why do we want to pursue a team-based approach, specifically for individuals with chronic conditions like diabetes? Looks like you might have to advance my slides there, Joe. Fortunately, sorry about that. Oh, want to highlight these words again as really critical elements of this definition. And you might have seen many different definitions for team-based care, and I think they're all likely appropriate and correct. This one just resonates with us a little bit. Great, thanks. So this chart shows us the patient and family outcomes associated with team-based care, as well as the team outcomes that we see when team-based care is utilized among staff. The outcomes aren't one-to-one across these rows, but rather the qualities in each column reinforce one another. I want to draw your attention to some of the patient outcomes we see as a result of team-based care, specifically adherence and self-care. Those are critical elements to improving diabetes outcomes specifically. Great. Next slide. Thanks. Finally, team-based care helps us achieve the quadruple aim, which is better care, lower total medical costs, more satisfied patients, and more satisfied providers, which was added recently to the triple aim as a fourth component. The quadruple aim helps us visualize the goals of team-based care, and it's a helpful reminder of why we put in the hard work to create, adjust, and optimize care teams. Great, thanks. So one of the major considerations for us is who is part of your care team? How do we make sure all the members not only understand their role, but are able to articulate the roles of others? So first, we want to make sure that all roles of the care team are understood and respected. Oh, sorry, maybe advanced that too quickly there. There we go. It's difficult to feel cohesive as a team if members aren't aware of their peers' unique contributions to team-based care in your setting. So to this end, the scope and responsibilities of each person's role should be clear. Scope could include the specifications pertaining to a person's licensure, or maybe their particular specialty as it relates to clinical care. And finally, make sure that each member of the team fully understands their role and how it fits into the care team. So many times our job descriptions don't fully, oh, sorry, getting some noise there. Sorry. So many times our job descriptions don't fully reflect what we do at our organizations. I'm sure that's true for me. I'm sure it's true for many of you that you sort of go above and beyond what is in your job description. And the same is certainly true for clinicians and other health center staff. So work with each team member of the care team to articulate what their role and responsibilities actually consist of. Good. So here are some of the elements that drive role creation and clarity. The members of your care team should practice to the top of their skill and licensure. Diana later on will talk to us about the particular skills and capability of community outreach workers and how they can be meaningfully incorporated as a member of the care team. As you're defining your care team, think of your patients' competencies, their values, and the factors that contribute to the achievement of their healthcare goals. Next slide. So like I said, we really want to think about the scope and licensure of each role. But I, again, want to emphasize that patients are at the center and play a critical role as a member of the healthcare team. So in team-based care, the patient and their family or community is at the center of any care team. While health center staff have clinical expertise, patients are experts in what it's like to live with their particular health condition. So patients can provide information about their own health experience. They can describe and report changes in health status, share the pros and cons of prescribed self-care and treatments, and identify factors that help and hinder their goals. Patient-centered care is the realignment of clinical priorities to fit with a patient's goals and choices and their capability at that moment. So while we can provide guidance based on our expertise, patients are ultimately the leaders in their own healthcare. So as we progress throughout this learning series, we're going to be discussing some strategies to empower and activate patients as central members of this care team. Next slide, please. Thanks. So I want to revisit Dr. Hilton's example of Mrs. Garcia. So what is her role on the care team? So as Dr. Hilton described, Mrs. Garcia has a couple of concerns. And without her expertise and her own experience, we as providers would be unable to know about some of those concerns and how we could best meet her needs. So she identifies aspects of her life that impact her care. Maybe transportation is an issue in accessing dental care or other services that she needs. She reports the dental pain and symptoms, including the pain that she experiences eating fruits and vegetables. So, as a diabetes educator, you might be prescribing a food plan, suggested food choices for Mrs. Garcia, but without her letting you know that she's unable to comply with that plan due to her pain, we really are, missing that opportunity to connect and solve what is really the root of the problem. Mrs. Garcia can discuss some of her other health concerns. So maybe there's isolation involved. Maybe she has other concerns that really impact her ability to adhere to plans of care. And finally, she can describe the resources that she has access to in the community. So maybe she doesn't have access to fresh fruits and vegetables or have access to other food sources that are going to be what helps her to sort of adhere to that plan of care. Again, really respecting Mrs. Garcia's role as an expert in her own care and as the person who will be carrying out these recommendations that we have for her as health center staff. Next slide, thanks. So I want to also kind of use another circular chart to think about who are the members of Mrs. Garcia's care team. So we can use a mapping exercise to sort of understand who plays a role in Mrs. Garcia's health. This exercise can also help identify whether there are members of the care team who are missing or unknown to us. As health center staff, we might want to take some time and create this chart with Mrs. Garcia's input to gather her insights about who is on her care team. So who does she perceive to be a part of her team and making her healthcare goals happen, and who might need to be included. So a care team doesn't necessarily have to be comprised of people who work in the same department or even in the same health center. It's anyone who might meaningfully contribute to Mrs. Garcia's health and well-being. And it's then up to us as health center staff to make and sustain connections with those partners. So again, as Dr. Hilton said, we have the diabetes educator. We know that maybe she hasn't accessed oral health recently, but oral health is certainly a component of her care team, or at least we would like it to be a critical component. Next slide. Great. So once we have identified the individuals on Mrs. Garcia's care team and defined each of their roles, including the patients, we can start thinking about strategies to implement team-based care. One of the tools we use to visualize team roles is a swim lane diagram. So a swim lane acts as a visual representation of a particular patient's experience at your health center. And on the next slide, I'm going to show you kind of an example of what a swim lane looks like. It's a little difficult to see, but you can see the link at the bottom where you can get a full view of this. But in this example, a swim lane depicts a typical physician assistant office visit at a health center. So each team member is listed on the y-axis, and then the various activities that that person is responsible for are listed across the x-axis. So notice that the patient is included as a member of the care team in this swim lane. Even though their only actions are entering and exiting the health center, it's important to put the patient on equal footing with other contributing team members. So this workflow mapping can reflect what is currently done at your health center, so you can map out a process that is already happening, or you can use it to create an ideal process flow that optimizes the role of each care team member. And in terms of Mrs. Garcia's experience, you might want to create a swim lane that explains how Mrs. Garcia's dental pain is reported, how care is coordinated, and linkage to care occurs between primary care and oral health care. Next slide. So another tool we find helpful in clarifying roles is a RACI matrix. So in a RACI matrix, we defined who is responsible, accountable, consulted, and informed for each task. So for our purposes, R, responsible, is the person or function that performs the work. So there must be one R for every row, no more and no less. And then accountable is the person ultimately accountable for the work or decision being made. Use this letter when appropriate, but not to excess. We don't want multiple people accountable for a particular task. And there can be from 0 to 1A in each row, but no more than 1. C is consulted, so that's anyone who must be consulted prior to a decision being made or a task completed. So a consulted person is typically a subject matter expert or a functional leader whose team will be affected by the decision. And there can be multiple individuals who are consulted in a particular task. And finally, we have I, which is informed. So that's anyone who must be informed after a decision is made or work is completed. And there can be as many I's as you like. So like a swim lane diagram, a RACI matrix is a great tool to identify each element of a particular project and the people involved at each level. So if you find that you're not sure who's doing what within a project or process at your health center, it may be helpful to build out a RACI matrix with input from everyone currently involved to identify activities for each person. So in the next slide, I'm going to show you a RACI matrix that I built out for Mrs. Garcia's situation. So next slide. So going back to Mrs. Garcia, let's sort of say, for example, that the health center she attends has identified, oral health disease issues among its patients with diabetes, like Mrs. Garcia, but may not have in-house dental care available. So the health center might want to establish a partnership with a local academic institution to meet the needs of its patients. In a team-based care model, we as a team will come together to create that plan and to execute that plan on behalf of our patients. So the key activities for building this partnership are listed in rows along the y-axis, and the relevant team members are listed across the top. So this matrix helps us visualize who is responsible, accountable, consulted, and informed about each activity. And it's important that all the team members are consulted about their role within the project. No one likes to be surprised by a task that they were assigned to and weren't sure about. So we want to really incorporate everyone's feedback while we're building this matrix. And we want this matrix to be available to the team so that roles and responsibilities are clear amongst one another as well. So one consideration you might make is how a patient might fit into this matrix. Could you consult a patient about the feasibility of a particular project? Could you identify patient champions within the health center? So not only should a patient play a role in their own healthcare, but they can also help improve the overall quality of healthcare delivery at your practice. Great. Next slide. So if you'd like to dive more into roles and responsibilities outside of this webinar, there's actually a free online module from Arizona State University that you or other members of your team can take. And the link is here. We is also included in the slides, which you have access to. So we'd be happy to provide additional resources as well, but feel free to go on to ASU site and take that module if you'd like to learn more about how to optimize roles and really define them clearly amongst your care team. Great. And the last thing I want to talk about today is role optimization, which I just mentioned. So again, Diane is going to go into particular detail about optimizing the role of your community outreach workers and community health workers, but how do you approach optimization for your care team as a whole? So on the next slide, we just want to talk about adjusting our teams according to the needs of our patients and communities. So a balance needs to be struck between the demand we experience from patients, from communities, from funders, and then the way that our team is staffed and organized. So appropriately configuring our teams can reduce provider burnout and improve the patient experience. So think about who is currently available to you at your health center right now. How is your team configured, and can we make improvements or tweaks that will really optimize everyone's role on the team, but also really help meet that demand that we experience at a health center? Next slide. So here are some principles that we want to keep in mind when optimizing someone's role at the health center. So all team members should work to the highest level of their expertise, skill, and licensure. And like I said before, the team composition is driven by patients and families, your population needs, but also by the characteristics of your practice. If you know that your health center has a particular patient population that really is either majority Spanish speaking or maybe has doesn't have as much access to transportation or other services, really building in tasks and roles within your healthcare team that help meet the needs of those patients. And again, look for potential cross-training to maximize flexibility and flow. So no one should be, the only person who knows about a particular process or task at your health center. If one person, is suddenly out sick or there's an issue or leaves the health center for any reason, it shouldn't completely disrupt the flow at your health center. We should have at least some level of cross-training available to sort of prevent some of those issues. Next slide. Great. And I also, just before we get to this, really want to bring this question back to the staff. So as you're thinking about role redesign and role optimization, what are their unique competencies and interests? So, for example, if you have an RN on staff who is interested in networking with community partners, you might incorporate care coordination and partnership as part of her role, and redesign an MA's position to take on some of the tasks that nurse was previously responsible for. So just keep in mind that all the activities must be within the current scope of an individual's education and licensure, but really take advantage of the interests of staff, their abilities, and their interests for professional growth as well. So I put together this list of primary care members and some of the examples of optimized activities that we can incorporate into their roles. And I'd be curious, as you reflect on this, if any of you have undergone team redesign, what are some of the enhanced responsibilities that you included in your care team? So we see for the RN, for example, maybe expanded care coordination and education, health education for patients, health promotion, chronic disease management. So just thinking about, again, what are the needs that we're seeing among our patients and our population, and how can we best utilize our staff to really optimize their role in meeting the needs of that population. Next slide. So I want to give you some additional resources about role redesign and optimization. These two reports are really helpful in kind of conceptualizing some of this. I also wanted to share a report that NNCC put out last year about optimizing care teams for diabetes management in particular. And so we'll be sharing that in our updated slides. Unfortunately, I forgot to put it in these slides now, but we'll share that in our updated slides, and I believe APCHA will be sharing that in the chat as well for you to access. Next slide. And again, there's actually a really wonderful module on Project LEAP. So it's primary care team redesign, You can go on here and get a lot of really great resources. And again, I would encourage you to not only for leaders and clinical directors or executive directors to access these resources, but really bring your team and your staff into this conversation and ask them if there's some interest in learning more about team-based care. I think the more we approach this as a team, even if we're not currently functioning as a team, that sort of really helps build that culture that we want to see as a result of team-based care. Next slide. We'll actually save final questions for the end of the presentation, I believe. But I want to, at this point, hand it off to Diana Lieu, who's going to be talking about community outreach workers, as I mentioned. Diana?
Thanks. Next slide, please. You can go ahead and go to the next slide. So my colleagues have done a great job laying out this link between diabetes and oral health, as well as the important role that care teams play, especially when you're helping people manage their chronic conditions like diabetes. I'm going to be talking about specifically some of these underlying frameworks that we've been talking about already, like care coordination and the unique role and function that community health workers or outreach workers can have in providing that care coordination, especially for our vulnerable populations. So this slide that you're seeing here, I wanted you all to have a chance to kind of glance over it, but right now there are a lot of frameworks out there. Like previously mentioned, it's in part because of this quadruple aim as a national driver for teamwork and the shift towards value-based reimbursement models. So first I want to talk about the difference between care management and care coordination, because I think a lot of these concepts, since they're pretty similar, end up getting conflated. So care management happens in a clinical setting, and care coordination can happen anywhere. So it could be in the clinic, it could also be at a specialist office, at social services, or in the community. So while care management is mostly clinical and focuses on a patient's medical needs, care coordination is contingent on a lot more things and includes varying social determinants of health. And what I mean by that is that care coordination services should be taking into account a patient's full psychosocial context, like their housing needs, their income needs, their social supports, and so on. So you can think of care management as high touch and episodic, and care coordination as something that's more holistic and broad. These two frameworks, they're obviously not mutually exclusive, so you see a lot of variations of them in practice, and I think that with most care teams, you're obviously doing a lot of care management. Some of it goes into care coordination, which is great. With the example that we've been using of Mrs. Garcia, there's a strong focus on her primary care. But in Emily's example, there's also coordination with a social worker and behavioral health. And so that really brings in this element of care coordination and going beyond her purely medical needs. And even though these concepts are pretty similar and have a lot of overlap, it's important to know that the systems of information, like the IT stuff that you need and that are involved, it's pretty different. So with care management, you need to be able to share medical information with different providers that might be a part of that patient's care. But with care coordination, it's more about that communication and coordination with external members of their care team. So folks who may not necessarily be in the health center, like mental health providers, home health providers, and so on. So it's information not only about a patient's social determinants of health, but also their clinical status, and it's a combination. So those systems are really different. Similarly, with the systems being different, it takes pretty distinct skills to provide care management and care coordination. So Emily talked about who should be involved in a patient-centered primary care team, and I'll be sharing about how these teams can kind of take their services to this next level of care coordination by including an outreach and community health worker. And I just want to mention that I think care coordination really recognizes that what is happening to people in their everyday lives has a really profound impact on their health and their engagement with healthcare. Go ahead and go to the next slide. So you've seen a few images like this already in this webinar, and it just goes to show how similar these concepts have and how much in common that they have. But this is a visual description of care coordination that we use at HOP. And in the middle, you have, instead of the patient, the primary goal of care coordination. So it's a little bit different in that sense, which is to improve patient health. The triangle outside of that represents the communication and collaboration. So really putting that in the center of the patient, the family, or their caretakers and the healthcare system, the broad healthcare system, not just within the health center, which is not, go back, which is not always included when you're talking just purely about primary care management in the most clinical sense. And then you have the outer layer, which is kind of similar, which represents a variety of care providers that work together to coordinate someone's health and social services to optimize their health outcomes. This isn't an exhaustive list. This could include a lot more people depending on the type of care that somebody needs. So the roles and responsibilities of care coordination really differ based on that team, but the underlying principle really is to try to increase that collaboration, the communication between patients, the clinicians, as well as the institutions that are serving them, so that you have an appropriate exchange of information as well as adequate delivery of health care and the social services that they need as well. Community health workers, which I've included here, are really ideal people for this type of concept and this type of team, because they are that link and they bring the experience and link between the clinic side. Since they're a part of the health center, they understand what's going on health-wise, as well as the social determinants of health side, which is something that's not necessarily easy or even possible to address in like the little tiny windows of appointments that we have for people. So they're really that like outside of a clinical appointment and outside of the health center, and when someone goes outside of the health center and lives their lives, they're that link for that patient. And outreach workers typically have a very close connection with the community that you're serving and can bring a really extensive knowledge about a particular patient's needs. Next slide, please. All right, so just bringing back the visual that Emily used before with Mrs. Garcia and applying the care coordination framework, you have all of the same players. I think I took one out to put the community health worker in, but the same people. You can put more. I just didn't know how to do it on PowerPoint, but you have all the players from the primary care team as well as the community health worker at the table. And even though the community health worker role is really different from your clinicians and your providers, for them to be truly successful and for them to be able to address the needs of the whole person, they need to have an equal seat at the table. And there needs to be coordination and communication not only between the providers as well as the broader system of services that Mrs. Garcia is using. There also needs to be coordination between the care team, obviously Mrs. Garcia herself, and perhaps if Mrs. Garcia, if her family takes care of her or she has a caretaker, all of that care and the coordination and communication needs to involve that person as well. And it's important to note that community health workers or outreach workers can bring a lot of that really needed cultural sensitivity and responsiveness that Mrs. Garcia and many others within the populations that we serve may need or may respond well, so that they can really feel empowered to be an active participant in their own care. And so it's really that equal footing that Emily was mentioning earlier. Again, this is not an exhaustive list of who could be at the table for this particular patient, Mrs. Garcia, and the people involved could look really different depending on the patient themselves, and community health workers are really the liaison for those individuals outside of your health center. Next slide. So kind of going back a little bit, I want to talk about who are community health workers, outreach workers. So the American Public Health Association defines them as a frontline public health worker who is a trusted member of and or has an unusually close understanding of the community served. This trusting relationship enables a worker to serve as a liaison, link, or intermediary between health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. Next slide. So while community health worker is a pretty commonly used job title nationally, they're still known by a variety of titles. At HOP, we use outreach worker because we think it's a little bit broader and captures what they do a little bit broadly. And I'll probably have already be using that interchangeably with community health worker, but it's important to note that all of these titles, outreach worker, peer health educator, health aide, patient navigator, promotor de salud, these ones that we hear a lot, the thing that distinguishes them as a role in community health worker is that they're a part of the community that they served, but they're also trained to communicate about health. And so they're in a very unique role within your health center. Next slide, please. So I've mentioned already a few reasons why you may want to consider community health workers in your care coordination, but here are a few other reasons. They are good liaisons to the community, and they'll be able to provide really unique context, perspectives, and information to your care team. And health centers that we've talked to nationally about including their community health workers and care teams share that the information that community health workers bring to that care team and bring to your table is really frequently is what determines whether or not someone follows through with their care. And having that community health worker on care teams can make a really big impact on a person's health outcomes, because they bring in all that information about, why isn't this person taking medication, or why are they not dealing with their diabetes? And they are able to then work with those providers to develop a care plan or a treatment that's actually going to be working for this patient. Secondly, I mentioned already before, but they can provide support by making by making sure that they that the services that are being provided are linguistically and culturally responsive. They can also improve the quality of care, which can lead to positive outcomes. And in fact, there's an evidence base for this. So including outreach workers in care coordination teams, particularly for patients with acute health needs or chronic conditions like diabetes. In a 2011 policy brief by CDC, they found that by integrating outreach workers into a care team, they were able to more effectively control those with hypertension among their highest risk populations. And that led to a really positive health outcome on those individuals. They also found that patients served by this integrated team of having a community health worker and a case manager, a nurse case manager, fared better than teams that didn't have them. So they fared better than teams that were solely led by outreach workers or solely led by nurse case managers. So I think it's really that collaboration between the community health workers, outreach workers, and your clinical members that can be really valuable. Lastly, I think Emily also mentioned some of this. They can help with cost savings by helping your clinic be more efficient and allowing providers to be working at the top of their licenses, because they're going to be doing a lot of the work that they're really well suited for doing, and your providers won't be having to do that work as well. Next slide, please. All right, so this is just a clinical study of the different roles that community health workers could have in a clinical setting. And this is a pretty recent one from 2015, and they looked across the country to see what community health workers were performing in terms of their work in the clinics. And they were mostly helping people gain access to medical services, advocating for their individual needs, teaching people and making sure that they know how to use the healthcare system as well as social services, and then helping people manage their chronic conditions. And it's important to note that none of these roles actually require a community health worker to perform any clinical work. And it's really, again, that peer relationship with the community that a community health worker has that makes them really well equipped to fill these roles and do these things for your patient population. Next slide, please. So we worked with the Center for Excellence in Care Coordination to develop this list of a more comprehensive list beyond the top roles of what potential role functions are and tasks are for community health workers within a care coordination team. And most outreach workers won't take on every role function or task on this list. It's just a longer list and kind of more in-depth that you can use to decide what makes sense for your organization. But most likely they'll do a combination of these, and some of these tasks may even be assigned to another member of the care coordination team, just depending on how you have your team structured. So you can take this list, think about what makes sense for your organization, what makes sense in terms of the things that your community health workers are already doing, and you could put it in your RACI matrix that Emily just taught us about. Next slide. So just kind of in summary, a community health worker can bring a unique expertise, skill set, as well as certain community perspectives to your care team. They can provide your care team with really valuable insight on a client's health behaviors that can ultimately help you make the best treatment decisions with your clinicians. And they should be treated as peers for this expertise that they bring to the team, but they shouldn't really be playing a clinical role on your team. Next slide, please. So lastly, I just want to share a few examples of care coordination that we have heard about here at Health Outreach Partners. So we worked closely with Alameda County in the Bay Area here, I think it was last year probably, to launch a county-wide oral health care coordination program. And I think this is just a really creative way that the health department is carrying out the concept of care coordination, even though it doesn't look like this model that we've shared with you today in terms of a more traditional with a care team type of care coordination. But I think that it's really cool that counties and different organizations around the country are trying new ways of bringing care coordination to the work that they're doing. So this program has a fleet of care coordinators who are basically community health workers, and they're stationed at health centers as well as social service organizations. And so they're not necessarily even working in the county. They are employees of the county, but they are also employees of these health centers as well as like social service organizations that don't have a health component. And their care coordinators work to help people, families and children specifically, enroll into a dental home. And the county does this other portion of the project is to recruit providers, dental providers who are interested in participating in their program and being those dental health homes. And along the way, they also the community health workers provide support to referrals and other social services as people need them. It's something that we identified really early on in the project that, if they're going to be working out in the community, oral health is certainly a concern for people, but probably not their first priority. And so what do they do to address those other priorities so that they can actually get to people to enroll into dental health homes? And their model includes 5 main areas, which looks like that community dental care workforce I mentioned, their network of dentists that are a participant of their program. They administer the program, obviously, and kind of going back to the systems piece I was talking about, they have a custom database in CCMS that they can use to accommodate this broader range of providers that's not necessarily within the same system or network, as well as all of the services that they're providing as care coordinators. And they also monitor evaluation of the project. Next slide, please. So this is just another practice that we feature frequently because we think that it's pretty innovative. It's from Benton County Health Services in Oregon. And for them, an integral part of their delivery of quality care is to make sure that they have community health workers involved in their care coordination program. So they have 22 community health workers in various roles, but for them, effective care coordination happens when all of the patient's needs are met, not just their medical. And through this network of community health workers that they have, they make sure that their patients' needs are addressed both in the clinic as well as in the community. And within the clinic, what they do, and what I think is pretty cool, is that they permanently organize their team in the same workspace. So sometimes you have like a provider room and your providers go and do all their work there when they're not seeing patients. And what this organization does is that they actually seat the care teams together. They have the community health workers working in the same room as their behavioral health person, as their primary care physician, as the nurses. And so that really helps their communication that's necessary to develop the appropriate care plans for each of the patients. And the community health workers bring in that extra information that people may need about why someone's not taking medication or why someone's not brushing their teeth or not able to eat the fruits and vegetables that they're being prescribed to eat. And then the care team's able to take that information and develop an alternative treatment plan or work closely with the community health workers who kind of see those patients outside of the clinic to provide the health education services that they need. And them working in close proximity together really increases the sharing of that critical information and ultimately has resulted in better quality of care for their patients. Next slide, please. So I just want to share this resource that we have on care coordination that we developed a few years ago. It's great for if you're just starting your program and you want to be thinking about how do you include community health workers. It's available on our website. It's at reach-partners.org, and check it out. I also forgot to include my contact information, but it's just Diana at outreach-partners.org. And so if you have any questions about any of the things I've shared today, feel free to email me and check out our resource. And I think that's it for me, Apcho. Thank you.
Thank you so much. Okay, thank you so much. Thank you, Dr. Hilton, Emily, and Diana for your wonderful presentations. That was very educational. For folks on the line or who are watching this webinar, we will now begin the question and answer portion of our webinar. As mentioned at the beginning, we will start by answering questions submitted to us during the presentation. If you'd like to submit a question now, please do so in the chat box in the right-hand column of your GoToWebinar screen. Feel free to direct your questions to any of our speakers here, to either Dr. Hilton, Emily, or Diana. We welcome your questions and comments. So one person has asked if these slides will be made available. Absolutely. These slides are actually available to download as a handout. If you go to the handouts section of your GoToWebinar control panel, you can download a copy of these slides in PDF format. We will also make sure to send out these slides as a link in a follow-up email to all the attendees after this webinar, and also these resources, the video recording, the slides, information about our speakers. They will all be posted on our website at diabetes.apcho.org. Sounds good. Should I just read it? Okay, so it looks like we have some questions. With PCMH, how do you engage the patient that just has no interest in doing that part? And it sounds like perhaps Emily and Diana, would you like to take that question on?
Yeah, so I think that's a really excellent question, especially since, you know, I think we all kind of mentioned how important the patient's role is as a member of the care team, and really an active member of the care team. But, you know, it's difficult if a patient says, you know, I'm not interested in, you know, participating. I don't really want to get involved in, you know, in going to a service or taking that advice or what have you. So what we can do is think about ways that we, you know, can engage that patient either through motivational interviewing, which is a really wonderful model that I think has been shown to really improve the patient activation experience. But we can also look at some tools that we can use to incorporate into team-based care. One of the tools that I really love to mention is AHRQ's Be Prepared to Be Engaged tool. It's actually a really wonderful resource, and I'm going to send it to the presenters so they can share it with you all. Send it right now so that we can send it. But it's a resource that you can access for free. It allows you to give patients, you know, some materials that they can use to prepare for visits with clinicians or other health center staff ahead of time, make sure that their questions and concerns are being heard. Because sometimes what we find is that, you know, a provider or a, you know, a health center staff member might be talking about one thing to a patient, but that's really not what the patient wants to, you know, be talking about in that given moment. That's not really their priority at the moment. So giving patients the tools to understand that we really want to hear what they want to talk about and want to meet them where they are. So that's one of the tools that I really like. I really like to share, and I'd be interested, Diana, to hear what you have to say as well.
Yeah, so I think the first thing that kind of stood out to me about that question is sort of the perspective. And instead of thinking like, why is this patient not doing their part, we should be asking, why is this patient not participating in their health care? Because I think that health is important for everybody, but things get in the way. And I think that this is where having a community health worker, someone who's part of that community, can be really invaluable in helping you move that needle with that patient. And them building this long-term trust with that patient. And I think that in terms of providers, what you can do is try to think about what is their context, recognizing what structures, whether it's social, political, or economic, that's influencing their decisions, or maybe it's not even a decision, maybe it's the only option that they have in the way that they're responding to their healthcare. So really like thinking about those things when you have a patient that is not really doing what you need to do. One time I was working, this was a long time ago in the beginning of my career, was working with somebody to provide a workshop, and she was saying how, she wanted to provide like OBGYN type of workshop for this immigrant population. And she was like, well, they wanted to come, but they kept coming and saying, we really need legal resources first. And so what she ended up doing was providing legal resources to them first, and then they were able to come back and like hear the information that they need to hear about their health care. So I know it's hard to think about these things that are kind of broad and like upstream that's happening to our patients. And we tend to work really proximally with the patients that we serve and the type of services that we provide. But if we can, I think that starting to address those things upstream is going to help people get to the place where you can start addressing things that are a little bit more proximal to their health. And community health workers all the way on this, yeah.
Great. Thank you so much, Emily. Thank you so much, Diana. We have another question from our audience. Can you say anything about how these types of interventions have translated into data and concrete outcomes?
We love data and we love concrete outcomes, don't we? They are, critically important. I think one of the things that is a struggle for folks is that when you implement team-based care, it takes a lot of work to redesign teams and to redesign the way things are done at the practice. And I don't know that we see a big return on investment at first. And so I think what we do tend to see later down the road is that there's a reduction in duplication of services in the community. Patients feel like they know where to go for services. And importantly, patients are maybe less likely to utilize the emergency room for primary care needs. So one of the things we saw in Philadelphia, we actually were part of a model where a health center was actually set up in an emergency room. It's a really interesting model where the emergency room was on one floor and the health center was kind of located towards the back, but still accessible. And, the health center, utilized a team-based care model, and the emergency room, staff were part of that team and really were able to link the patients right away to that health center that was able to provide care for those folks who were experiencing less acuity. And so we actually found that there was a lot of cost savings in that, but that also patients, for once, really knew that they could go somewhere that wasn't an emergency room to understand who was part of their primary care team, as opposed to an emergent situation. So that's maybe one of the considerations we want to think about. And if you're talking to leadership and want to, really onboard teams, think about those overall healthcare cost savings that you might be able to find. If not in your practice right away, then certainly you can make a case that it does save money for the system.
Okay, thanks so much, Emily. There's a follow-up question. In creating the care plan, where do you have the CHW and provider meet? Is this before the visit, after the visit? And how often does it take place? Once a week, twice a week? And Diana, this may be a great question for you to answer as well.
Yeah, so I think that for the health centers that we've talked to who have community health workers or a part of their care team, it's whenever the care team meets. And so some health centers, they have like a morning huddle, and the community health workers there every single morning huddling with the providers. If you're meeting before the visit or after the visit, it just depends on sort of, I think, the clinic process. We know that some health centers have the community health worker check in with a provider before a patient, especially if it's a patient that they've identified that needs a little bit extra work with care coordination. And so, you know, it could fit within your flow, your clinic flow, just depends on what you all do.
Great, thank you. We have a couple of questions related to buy-in. The audience is asking if, for Diana specifically, you know, do you have suggestions on how to convince leadership to use models like this? And for anyone on the panel, you know, how critical is it to have that admin buy-in in using community health workers and care team models?
This is a really good question. It's something that we keep on advocating for and we keep trying to do with health center leadership, and it can be really difficult. So with the care coordination programs that have been really successful, it's when a provider and your clinicians are actually telling leadership that, hey, this is really helpful, we like piloted it, and the information that this person is bringing us has been invaluable for this person's care. And so having the providers buy in first and then kind of going up if possible has seemed to work, but I have to be honest, this is something that's really difficult for us, and we're still really trying to tackle. We've been doing some trainings around like structural competency and addressing structural change things, and all of those things require leadership buy-in. I think that this is something that the needle is moving towards slowly, but it's slow.
Thank you.
It's very critical to have admin buy-in. It looks like this was one of the other ones. Yeah.
Absolutely. Thanks so much. Emily, this might be a good question for you from one of our audience members. For team-based care, the RACI matrix seems like a great tool. Do you have any other recommendations for training materials or resources for staff to learn how to work well together as a team?
Mm-hmm. Yeah, that's a great question. I think there are some really great tools out there, and I think it really does depend on where you are in the sort of continuum of care teams. I know in our poll, a lot of people said that they operate within care teams, but you know, we all know that that can look really different depending on where you are. So one of the first things that I recommend when you want to get a sense of how things are going and if folks feel like they are part of a care team is doing some kind of an assessment. So at NNCC, we typically recommend what's called the ACE-15 assessment. And I'm not sure how familiar everybody is with that, but I'll also, sorry I didn't provide these links before, but I'll definitely provide it right now for the organizers to share with you. But it's actually a great tool to assess the level of teamness of your staff. So how you know, incorporated do they feel in the care team? Do they feel like their role is understood by others? And then you can kind of see based on that the results of that, what are some of the particular things that you might need to work on as a care team? So Diana mentioned huddles, which was great, and I think huddles are kind of a tough intervention to wrap our heads around. They can look really different everywhere, depending on, you know, if we're having a huddle for a particular disease state, if we're having a huddle for particular staff members. So even just some huddle toolkits or checklists, or even just, you know, even a RACI matrix about how are you going to implement huddles, or what do huddles look like here. Some of those sort of bare bones things might be really helpful as you assess and then improve on things that you already have in place. But again, I would encourage you to look into doing an assessment like the ACE-15, but then maybe also pick, you know, one intervention like a huddle, for example, and maybe dive into that with some resources that you can access. And again, please feel free to reach out to me, and I'm sure any of the speakers for resources, and we'd be happy to share those with you.
Great, thanks so much, Emily. We have a question for Dr. Irene Hilton. This audience member asked, we may have the ability to place a dental hygienist in the medical office. Do you have an in-depth outline for what that would look like?
Yeah, we do have some. Now, this is kind of interesting because that's actually like an emerging model, the idea of placing dental providers, whether it's a dentist or a dental hygienist, in the medical side. again, as an adjunct to increase access to care. And so we do have some best practices on our website, and some examples from some health centers that have presented at our annual conference on how they have implemented that model. I would have to get you like the links. So actually, if you can chat in your contact information, I can give you the links. I can send you the links for those particular examples. And we are actually in the process of developing a survey right now that we are planning on sending out later this year to health centers to try to assess actually what the penetration and prevalence is of that type of model, again, of embedding dental staff in the primary care side. But thank you for the question.
Thank you so much, Dr. Hilton. We have one last question from our audience, and this question is, how do you document primary care services, codes or screeners, and electronic dental records? This person says that our clinic offers screeners for substance use disorders and have a behavioral health consultant who offers brief interventions. However, the biggest challenge we face is documentation of the brief intervention in the electronic dental records. So, Dr. Hilton, could you help answer this?
Yeah, so that's that can be tricky because, again, it depends on the relationship between your EMR and your EDR. If you're on a relatively integrated system like eClinical works and using both modules, or NextGen and QSI, you can bill and code. Now you could code those procedures in the dental, but really they would shift over to the medical side, and that's where you would actually see them. I mean, you can do ICD-10 coding on either side for whatever the condition is, but if you have behavioral health people in the dental clinic, I mean, there's a lot of different ways in which you could do it. You could just have them bill. If they're behavioral health people, they could be billing on the primary care side, even though the procedures are taking place in the dental clinic. It would almost be treated like another site. So it depends on what the situation is in relation to the EMR and EDR you have. And I know that there isn't, in other words, there isn't one solution because there's so many different relationships between the two systems and the ability to who's doing the billing, that I can't really give you a good answer without knowing what your exact configuration is. It's a challenge. That is a challenge. So again, if you email me, we can help you figure it out.
Thank you, Dr. Hilton. There's actually just one more question, and this will be our last question for today's session. This person says that we recently inherited a mobile dental facility. Are there resources I might refer to our dental director?
Yeah, there's a bunch of, that actually would be a great way to expand access to care, especially let's say you wanted to go to, let's say your health center has 7 primary care sites and maybe 2 have dental. That would be a great way to take some of your staff or hire new staff that can go out to the other sites that don't offer dental services and do, treatment or screenings or prevention or multiple services. There's a resource online, the Safety Net Mobile, that just Google Safety Net Mobile Clinic, and you'll get .org. Just Google, I said Safety Net Mobile Clinic, and you'll get a resource that pretty much covers soup to nuts from starting up mobile programs. And we have a resource on the NOAA website on school-based health centers that, again, is one of the most common ways that mobile vans are used, if not to go to other sites of the health center, it's to go to schools. And there are things though that you have to do, in terms of changing, your Form 5. If you already offer dental services, and again, it depends on where you're going to go. It's an existing site of your health center or a new site. There's things you have to do for the HRSA compliance with your project officer, or we can help you with. So just chat in your information. We'll email you. Oh, thank you.
Thank you, Dr. Hilton. Okay, well, that concludes our Q&A session. These were such great questions for our speakers. Thank you, everyone, for submitting them into the question box. And if you have any more questions, you're more than welcome to send them over to us by email. We'll provide some email addresses at the end of this presentation. I just want to thank our speakers for today's wonderful presentation and everyone for their time to attend our learning session today. Please note that we have 3 more webinars coming up in our 4-part national learning series to talk about diabetes prevention and management and the comorbidities associated with diabetes. For more information and to register for these next 3 webinars after this one, please visit our website at diabetes.apcho.org. I just want to give you a sneak preview of our next webinar, webinar number 2. This will focus on diabetes, again, the diabetes continuum of care, and specifically using behavioral health and substance use disorder integration to address older adults with cognitive impairments and diabetes. And the National Cooperative Agreement organizations that will be hosting this webinar session with their expert speakers will be National LGBT Health Education Center, a program of the Fenway Institute, the National Center for Health and Public Housing, and the National Center for Equitable Care for the Elderly. So this webinar will take place on Tuesday, April 9th at 11 o'clock a.m. Pacific time or 2 o'clock p.m. Eastern time. Again, to register, please visit our website at diabetes.apcho.org. So with that said, we'd like to ask that you kindly take 30 seconds to complete the survey that you will receive after today's webinar. We really rely on your feedback to improve our resources and ensure we are addressing any pressing issues and challenges relevant for your health insurers, patients, and staff and providers. For more information about our Diabetes National Learning Series, please visit diabetes.apcho.org, and you're more than welcome to contact our fabulous speakers here whose contact information is listed here in front of you for Dr. Hilton, for Emily, and Diana. So once again, thank you for attending today's session. Have a great rest of your day. And the session has now concluded, so you may exit out of GoToWebinar. Thank you.
Thank you, everyone.
Thank you.